I'm also afraid to follow people like David and his colleagues because I was on this catastrophic determination panel. There are a couple of caveats that I think we have to put on the table before we go much further. I was also on the 2000 CAT panel. If you read that report in its detail, there were a number of recommendations, many of which were completely ignored by the bureaucrats and FISCO. We don't know where it's going to go, and certainly in times of election, we don't know what that's going to impart, whether we're going to go more liberal, more democratic, NDP, who knows, and what that's going to do to the FISCO themes and directions. So part of what I want to do is talk to you about the catastrophic injury definition and the impairment process, but more importantly, I want to get deeper than that and get into what the science, the literature, and our clinical experience tells us about severe traumatic brain injury in children and their outcomes. Because governments change, policies change, legislation changes. And trying to match the policy and what is written in the legislation to what is real life is often extremely difficult. So that's sort of the caveat that I bring to this. First and foremost, it's very clear that catastrophic injury is not a medical definition. It's not in the medical literature. It's not in the rehab literature. It is a term that was adopted when the process of putting together the legislation was brought forward to try and gather up this is my own personal impression, gather up a group of individuals that have bad outcomes and how do we put them in a category and then provide appropriate resources. The other caveat to the legislation from my own interpretation is that there was at least some thinking that some people do very poorly because of their injury and they need access to greater rehab resources. And those that have milder injuries tend to do well, therefore they probably don't need as much. And if we're going to fund this, how are we going to do it and how are we going to make it cost effective? So that means a lot of legislation. That means a lot of analysis of things like how many get injured, how severe are they, what are the costs, what are their long-term outcomes, and so on. And that's a study that will take one person their entire career, and it's still not there yet. So the other thing that you'll clearly see in the past legislation and even the current legislation we're working on is primarily adult tools that were written into the legislation. Glasgow Coma Scale, as David just very clearly pointed out, was a pediatric, it was not a pediatric score in its initial development. It was meant for adults. Now there is a pediatric GCS, and if that paramedic is aware of the pediatric GCS or the individual goes to a trauma center where they have experienced traumatologist with children, they will get a reliable pediatric GCS. Glasgow Outcome Scale, never intended for children. It has a lot to do with can you live independently, can you work independently. Of course, these are things that are inappropriate for children at this time. The AMA guidelines. I was also on the AMA guideline critique panel back in the 90s when it first came in, and they said, how do we use this with children? So we went and we actually investigated with the authors of the 4th edition because we are restricted to the 4th edition. And they said, oh, it's never meant for children. This was first developed for adults for access through the American Medical Association consulting with social services in the US to see who has a long-term disability. So you're using a tool that was never developed for children. And that's why the legislation is written in what I would consider kind of muddy wording, because it's not science, it's not logic, it's not hard and fast rules, it's not bright lines. And so is there a way to define things more clearly so you don't have to find the good assessor, versus the bad assessor, the flexible assessor versus the inflexible, and you are able to say, here's the evidence, here's the science, here's what the anatomy and physiology shows us, now what do we do? And that, I hope, was the intent that was coming across with many of the decisions that came forward. The catastrophic determination panel was given the mandate of finding what the evidence was. Wasn't told to evaluate the policy, wasn't given data on specific costs and that sort of thing. That's the bureaucrat's job. That's the legislator's job. That's the job of the community to lobby and push in the direction it should be. And I certainly support continuing that. So the proposed definition, as you so aptly laid out, is interesting, and I can really speak to the pediatric one. What we're trying to do is say, okay, if the science says the GCS isn't terribly helpful, and it's very clear in your own clinical experience, you've seen children with GCS of 12 who have moderate injury who do terribly. You see some children who have GCSs of 13 and 14 who also have severe problems. You see those that have terrible GCSs for a short period of time, bounce back beautifully, and seem to go on through life with very few problems, if any. So how do you muddy through this? Well, you go back to the literature and say, what is a severe injury? And a severe injury is that injury that has affected the central nervous system. And how do we find evidence of that? In the physiology, the loss of consciousness, in the changes in neuroimaging, and I'm hoping in the near future we'll also have some very valid lab tests that we can say, you know, this level of protein from the CSF and from the blood is so high that we know there's been significant injury and it's going to be a problem. The other thing is, how can you quickly say these people are the ones that have been injured and need help and should get into the system with greater access to rehab services? And that's the thinking behind the inpatient admission to a level 1 trauma center with a diagnosis of traumatic brain injury that has some evidence to prove it. And that means CT, MRI changes of some sort. And we tried to give a fairly exhaustive list to give the direction to those that have to deal with it, saying, well, maybe a blood clot's not that important. And we're saying, yes, it's a positive finding on a CT scan. We're also very aware of research from Harvey Levin and Maureen Dennis, where those kids with moderate traumatic brain injuries who had GCSs of 12 but had positive CT scans are the ones that did poorly and were just like the kids with GCSs of 6. And so that's some of the thinking. Now, not everybody goes to a trauma center. It's very true. But most do get referred to a publicly funded rehab service. And as you can see, this is one of the thresholds. If they're referred because a physician who says they've got a traumatic brain injury and they need rehab, is that significant enough to say they should be identified? I certainly think it is. Now, we also know a limitation of public beds. That should be fixed. I can't fix it. We need to improve that. But we also said if they're eligible, even if they don't make it in that first week, first 2 weeks, they should meet the threshold. So you don't have to sit and wait and say, okay, now they're through the door, now we can do that kind of assessment and get them the funding. So we hope that that's feasible and easy enough to use. Now the print gets even finer. My apologies. Over the age 50, I find this harder and harder to do without my extra strong bifocals. But what you're seeing is that we also knew that not everybody was injured in Ontario, not everybody goes through a trauma center, not everybody goes through an outpatient or inpatient rehab program that is available. So how else do we make it obvious? And we go back to the thinking that was behind the GOS. If you can prove from a functional assessment, the Glasgow Outcome Scale, that the person has significant problems, should they be eligible? Yes. Well, the GOS isn't any good for kids. It was never developed for them, and you have to wait till they're 17 or 18 to apply it, or you have to prognosticate. And I hate that. And I'm asked on a regular basis. And I know that I get to follow people until they're 18, 19, 20. But even with that experience, I find it incredibly difficult. So, is the research there to say this one is more likely to have problems, this one isn't? Well, the best we could find was the CAUCHI, the King's Outcome Scale of Childhood Head Injury. It's a first flush. It doesn't have all the rigor we'd love to see. It isn't the strongest tool in the world, and it's only been around for about a decade. So we know it's not perfect, but at least it was developed thinking about kids. And we tried to look at the threshold and say, okay, if they're very severely impaired and their function is significantly reduced early on, that's enough. Let's get them into the system. If they don't meet that, but that impairment lasts for a longer period of time, that's the second threshold. And you can see on the third one, the function isn't as badly impaired, but still it is persisted for a significant length of time. And we tried to think about, well, how long does that current level of non-catastrophic funding burn out? Sometimes it's 6 months, sometimes it's a year. So tried to find a middle ground where most individuals would be able to transition from one to the other without falling through the cracks. It's perfect? No. But at least it's a second pathway into the system to make someone eligible. So, clearer approach? Well, a clearer approach would be going back to the actual literature and to the science and say, get rid of that word catastrophic. But that's not going to happen. So, how do you extrapolate? Well, you go to the literature and you say, who is a child that has a severe traumatic brain injury? And this is what the literature tells us. We know that those with GCS 8 or less supposedly are the severely traumatically brain injured. Well, if you go to Glasgow and you talk to Jeanette and Teasdale, why did they develop the GCS? They developed it to communicate from one neurosurgeon to another, one traumatologist to another, about how severe is this injury and is the person likely to survive the next 48, 72 hours. That's what it was meant for. And it's very good at telling you that. But it's pretty poor at predicting long-term outcome. I've seen individuals that have had 20% of their posterior parietal and occipital lobe contused because of depressed skull fracture who are quite cognizant, talking, walking, and show no loss of consciousness. They're severely impaired with a GCS of 14. So, if there's diffuse injury to the brain that interrupts the working of consciousness and they have post-traumatic amnesia for 24 hours or more, the literature is very clear that that's a severe traumatic brain injury. And that's probably the best predictor of who's going to do badly and who's going to do well, even if their GCS wasn't so bad and even if their CT scan is clean. But not every hospital does this. We don't have enough OTs at the bedside doing serial PTA assessments to make this a functional tool. It's like saying everybody should be able to analyze the P100 level, but it's not available in every single hospital, so how do you make a tool that is easily applied? And finally, we know that when you go to the literature and somebody has traumatic brain injury, if they have multiple complications like infections, anoxia, persistent hypotension or shock, or if they have a foreign body in the brain, that adds to the severity of the injury. So that's just basic assessment of traumatic brain injury. Then we get into the challenging assessment for children and prognosticating. Well, growth and development is not a lockstep process. If you have more than 2 children in your family, you know they're not the same. Even the identical twins tend to do things a little bit differently. So there's the nature and nurture balance. There's a lot that is genetics, but there's a lot that comes to us because of our experience and what happens. And in fact, you can even get down to the DNA level in an individual with two identical twins. And at the end of a couple of years, you can identify subtle differences in the DNA because of their experience and what they've been exposed to. As David talked about, there's a large problem trying to assess functions in children that haven't developed yet. I remember my favored leader in pediatric ABI and TBI, Mark Ilvasacker, describing someone who has high impulsivity, short attention span, tends to get verbally aggressive very quickly, thinks everything revolves around them, just absolutely tantrums when things go wrong. You're describing someone with severe frontal traumatic brain injury? No, you're describing a toddler. So what are you trying to do? Well, a toddler hasn't developed their frontal lobes. And someone with severe traumatic brain injury who's lost their frontal lobes is in a different situation, but functionally behaves very similarly. So it's that developmental impact that is so hard to ascertain. So again, we go back to the science. We know there's variability in recovery. We also know that the impact of an injury at timing at the time of injury in the development has a different outcome long term. And although I still hear it, I can't believe it, I've been doing this for 25 years almost, and I'm still hearing, oh, kids recover better than adults. I heard it at a conference run by colleagues similar to you just 4 months ago by a neuropsychiatrist, and I'm going, please. It's not true. They recover differently. That's true. They recover better from a physical standpoint in many ways. That's true. But from a neurocognitive and behavioral standpoint, they often, and in most cases the literature is absolutely clear, they do worse. The younger you are at the time of traumatic brain injury, the worse your cognitive developmental outcome is long term. Please take that home. Please spread the word. I'm beginning to sound like a preacher banging on the podium, but we've got to get that out there. And going back to the literature, Klonoff in '77 started to prove this. Helps if it's the right direction. He was actually saying, look, we're finding these issues, and he started looking at follow-up in children and broke them down into two basic groups. 9 and under, 9 and older. He looked at their neuropsychologic outcome, their neurologic status. So that's, do they have strength in an arm? Do they have coordination? Do they have balance? Very crude kind of issues. Do they have abnormal EEGs and seizures? And then how they do in school. And he found there were differential recoveries over time, surprise, surprise, but greater educational, neurocognitive, neurobehavioral problems in the younger group. And a full 1/4 of them had neurologic sequelae long term. That means they had a stiff arm, they had poor balance and coordination, they had double vision, they had something that was visibly discoverable on a physical neurologic exam. And a neurologic exam done by an excellent clinician can be a wonderful thing to watch, but it's still a pretty crude assessment of neurocognitive function. Levin and Eisenberg in '79 looked at 45 children, graded them by severity, used the 3 mild, moderate, severe severities that are commonly accepted. They looked at 3 age groups, broke them down a little more finely. So preschoolers up to kindergarten, primary school age, and then teenagers. They saw a clear relationship between the severity and age at time of injury. What I should have put in this bottom line is the younger they were, the worse off they were. Kreil, Kroc, and Panzer, again, similar outcomes in '89. Older children had better outcomes. Worse problems seen in relationship to the distance of referral from the trauma rehab center. Well, that's pretty obvious. If you don't get the right treatment at the right time, you don't do as well because you have worse cerebral edema, because you have worsened blood pressure or anoxia or any of those medical problems. The other thing is scan. which is suspected child abuse and neglect. That's our local term at Sick Kids. Other hospitals, other places call it Trauma X, or many different terms. But basically, abuse causes worse outcomes to the individuals. And one of the reasons that has been formulated is that we think the abuse doesn't stop when the person loses consciousness. Often what happens is the abuser will hit the child, throw the child, bounce the child on something a number of times before they stop. And the child has lost consciousness, so they have no protective reflexes, they have no ability to stop what's happening. And so often you see that diffuse type of injury that persists. The other thing, abusers often then regret what they've done and hope that it's all going to be okay, so they don't get the individual to care on an urgent basis. So, well, when you look at things over the longer term, how do the individuals do? Well, Inger Thompson, one of my personal mentors, although she has no idea who I am, she's never met me. She is a physiatrist who has followed her patients for over 40 years and just reports on how she's seen them evolve and develop. And she looked at those patients that she was following who had had their traumatic brain injuries as children. And the younger the time of injury, the higher the risk of late behavioral and emotional sequelae. No surprise. Here we have in 1990 similar sort of findings. 5 to 11-year follow-up. This is good long-term follow-up. Long-term follow-up that is under 2 years isn't long-term. What it is post-acute. The median duration of 3 weeks, 1 fatality at 9 years, 30 recovered consciousness and were able to leave hospital. 24 had long-term disability that was significant. Only 26 had independent mobility. 7 had epilepsy. 14 had trouble speaking with dysarthric. 10 had cognition sufficient enough to be able to return to school, but none of them got on to post-secondary education. So that's a pretty bad outcome. We actually see much better results than that now. Tompkins Holland and their team looked at 84 children, again looked at severity. Pre-injury intellectual challenges were the best predictors at time of discharge, again in children older than 9. The younger children, interestingly enough, if the parents weren't together and weren't supporting, was also a key factor on how well these children did. Older children were performing most poorly, remained those most impaired. So if at a year the individual was doing poorly, they didn't make a great burst and a quick turnaround after the year and a half. So by that year, you can get a fairly good idea of where they're going to head in comparison to their peers, but it's not perfect. Boyer and Edwards in '91 looked at a bigger group. They assessed mobility, ADL, education, cognition, a really nice spectrum of outcome. Whether they were conscious upon admission was a good predictor. Whether they had a persistent coma for 6 months. If children ride the coma edge, in other words, they stay comatose for 3 to 6 months, they do not do well long term. Only 14% returned to regular education, 25% unable to benefit from any sort of education. So this is a very severely impaired group. Jaffe and his group studied almost 100 children. They looked at neuropsych testing. Those with moderate and severe traumatic brain injury performed normally related to their peers with their IQ. A simple test of basic awareness and interaction. But there's a pattern of decreasing performance relating to the severity of the traumatic brain injury. So it's a very clear dose-response curve. They also noted that at a year, these 94 children who are compared to a cohort of normals, that again, the more severe the injury, the worse the outcome. Strongest correlates were the severity impacting intelligence, academic performance, and physical function. those with mild traumatic brain injury, those with concussions, those with GCSs that never dipped below 13, who didn't have anything on CT scan, they're the ones who appeared to recover completely. So, because of time, I'm just going to let you read the rest of the literature, but it's very clear that this is a persisting pattern of outcome. We know that those that are less than 6 are probably the individuals who are going to do the worst. And again, if it was as a result of abuse, they're likely to do very poorly. CNS imaging is coming into its own now. We're starting to be able to see not only the basic blood clots and bruises on CT scan, but the MRI is starting to be able to not only look at the physical structure of the brain, but trace pathways, look at function. We can't clinically do functional MRIs yet, but I'm sure that this is going to be a tool that evolves and develops. And so you'll be asking for functional MRIs on your clients' executive function, on their problem solving, on their language, and being able to discern those with impairment and those without. But Himonen in 2005 looked at long-term outcome and the MRI, and they saw this impaired memory function, memory complaints, and executive function that looked at the hippocampus, which is part of the brain that has all of our new information processing through before it's stored, and looked at the lateral ventricular enlargement. Fancy way of saying, looked at the white matter in the brain. And the white matter, the brain is the part of the brain that gets the diffuse insult. And it shrinks after significant injury. And so when it shrinks, the lateral ventricles enlarge because nature abhors a vacuum, and it fills up the space. And so looking at that white matter volume is a crucial thing to say, is this brain normal or not? And he was one of the first to really put it clearly that there's this nice correlation. And again, he said that the degree of diffuse injury with atrophic changes is prognostically more important than initial severity of the brain injury. And we found this kind of correlation as well, because when we've looked at our own database and our own outcomes from our clinics, we've tried to correlate where the bruise was, where the blood clot was, where the bone flap was. None of that terribly correlated to outcome long term. But we do see this kind of correlation emerging. What else? Well, children are raised in families. Good families raise good kids. Chaotic families don't have the structure to be able to help and foster and support and advocate the way they should. And so a high-functioning family significantly moderates the effects of more severe traumatic brain injury compared with those who are low-functioning. So there's that effect. And this effect doesn't mean that they're high-income families and from a high socioeconomic demographic. High-functioning families are cohesive families, and they may be poor, but they are able to work together, support each other, and advocate. And that's what seems to be the bigger outcome. Clearly, we saw in our own data the age differences. Those who had their injury below 5 tended to have the more obvious deficits and the longer-term problems, the physical issues like ataxia, poor balance, spasticity. And there's a linear trend which older age injury is positively associated with improvement in the Mayo-Portland Adaptability Inventory. I can translate that for you. The MPAI is a tool that gives you an assessment of how well the person is doing from a cognitive, behavioral, and physical standpoint. And we saw that when you were older, you did better and recovered more. Clearly, there are long-term problems such as anger, reduced endurance, reduced initiation, reduced processing speed. Things you're going to hear from Dr. Lemsky and Dr. Hay later today about the neuropsych assessment and where you're going to find problems. We also found that about a half of the families with children who were injured at under age 10 really reported significant concerns about their children's anger. anger at home, anger affecting their peers, and how they're doing at school. For children and adolescents who are older than 10 at the time of injury, anger was still an issue, but it tended to wane after about 2 to 3 years. Verbal anger, of course, was more common at first, but by the time we were following people 4 years out, we were seeing consistent physical aggression as well as verbal aggression. Now, we expect to see that because we expect that those individuals who are doing very well aren't going to keep coming back to see Dr. Rumney. You know, it's a waste of time. So we expect we're going to be seeing the tip of the iceberg. So, persisting limitations are seen. Academic performance is an issue. The pragmatic communication skills clearly are a significant problem, limiting social interactions and their effectiveness, as well as their physical abilities. And I'm sure you've all seen this in various forms, showing the age maturation of the brain from age 5 on to age 20. Us with Y chromosomes, it's about age 21 when we finish maturation. You with 2 X's tend to do it a little quicker at about age 18, but the myelination of the brain, the removal of the pure gray matter on top and adding to that myelination, improving efficiency and efficacy of all parts of the brain, but specifically the frontal lobe, doesn't finish until late adolescence, early adulthood. There's also the key pediatric problem of cognitive stall, and this has become evident in literature in the last decade. What we're seeing is that prefrontal cortex and its connections undergo significant changes during adolescence. We know that. Changes underline important cognitive developments, and it seems that there are certain individuals never attain what might be called the mature frontal lobe because of their injury. So the current research is still thin. It's not as deep, not as broad, not as helpful as we'd like it to be. We know that there are certain tools that are pretty good for telling physical functioning, basic skills like ADLs, the WeFim is very helpful. The GMFM and the PEDI are excellent tools to help in looking at motoric function, transfer abilities, mobility. We're trying to refine the COSHI. We're trying to get some research that will say, okay, is this really good tool or not? And we're hoping that in the next year or two, we'll be able to answer that question better. We know that we have the tools that are well validated with respect to cognitive maturation, the IQ, the neuropsych assessment. But again, that's an assessment in the optimal environment with minimal distraction and is not often easily translated into the real world where Johnny's sitting in the back of the class with 16 other kids, 14 of which are throwing spitballs, and there's no way he can focus his attention because the teacher's not controlling the class. All those sort of factors. You need time to allow, develop, and evaluation. So I'm constantly telling the gentleman down here, wait, don't get into it yet. Do it later because we'll have a better, clearer idea. But sometimes your hands are bound. We know that family structure and function, their impact is sizable. We know the psychopathology can disable despite normal cognition, and so that's why there's the big discussion about Chapter 14 versus the other chapters in the AMA. Should the psychopathology be added to? And if you've ever tried to do the AMA guideline summation, 5 and 5 and 5 does not equal 15. It equals about 11. So it's a strange and arcane process. Current rehabilitation and compensation is being refined and improved. New techniques are coming out, new strategies, new prostheses, both electronic and digital as well as physical, and so we're hoping to make a better impact. So I have to apologize. I can't be more definitive at present. The research is progressing. Science is refining its assessment tools, neuroimaging biomarkers. What we're trying to do is make it as objective as possible. Find a test that is reliable, that helps us parse out who's going to do better than others. When I started in '87, I said, oh, I could do this. We'll sit down in 4 or 5 years and we'll be able to tease this out. Well, boy, the enthusiasm of use. So rehab is still evolving. Evidence is improving, getting more objective. The trouble is, as you know, you're at Sick Kids. There are individuals doing fMRIs for research, and there are individuals doing fMRIs to help out in evaluating those people with terrible seizures as to where the seizure is coming from and what part of the brain they can remove to improve it. But nobody that I know of is doing fMRIs with traumatic brain injury. So we're hoping that we can push that a little further with some of the research that's coming down the line. But clearly, to be definitive, you'd have to wait until maturation finishes. But I think there's a lot of information that could be gleaned by doing serial fMRIs as a person develops, and then marry it to these neuropsych assessments, the speech development, all those sorts of things. One of your neurosurgery fellows is trying to develop a really good outcome tool for children at school, and I think that's going to be helpful as well. The question was, is there information about sensory evoked potentials and outcome? I know that in the assessment of mild traumatic brain injury, there have been some articles that talk about changes in the ABR in the late phase ABRs that relate to the neurocognitive processing and the symptoms, and that when the ABR improves, the symptoms seem to improve. We also know that in the case of anoxic brain injury in children, if the sensory evoked potentials are aberrant or abnormal, that's a poor prognostic sign. But that's as far as I can sort of talk about the literature that I'm aware of. Certainly functional assessments often, and in our facility, fall under the purview of occupational therapists. But a very skilled neuropsychologist can be a valuable speech-language pathologist, nurses who have had a lot of pediatric experience. So there isn't a plethora of people to choose from to be able to say they always should be done by this person versus that. And that's part of the challenge, even with the CAT assessors. Yeah. Yes. But I'm going to defer to my colleagues who are going to be speaking specifically to the neuropsych assessments and which components are regularly seen after traumatic brain injury, which components are likely to lead to issues of long-term problems, and which part goes to where. So, okay. The question was, how do you tease out the pre-existing problems from the injury, i.e., child with ADD, a child with learning disability, a child with autism who then has traumatic brain injury? Best way is if you have perfect evidence before the injury and then you have good evidence after and you can compare the two. But most individuals don't come with a neuropsych, a SPECT scan or a functional MRI before they have their injury. So clearly, when you have a consistent story, a consistent pattern of loss of function that relates to the trauma, and this loss of function persists and it's consistent with the neurologic findings and it's consistent with the neurocognitive assessment, then I think you have a pretty strong case. I have the luxury of saying I don't have to worry about that. I have to worry about what the client has, what the patient and the family are dealing with right now, and where do we go from here? And I often go to some of my colleagues who have expertise in developmental issues, LD, ADD, Asperger's. So my reading of the legislation is it don't matter. Because if you meet the threshold, coming into it you had this, and then because of your injury you fall below the threshold, you now meet the threshold. That is my interpretation of how things should be. I'm not saying that's what the legislation says, what our courts are going to say long term, but clearly I believe, is it the Desbian decision speaks to that, and I think that makes a lot of sense. So don't sign me up as a lawyer. I just can't do it. Thank you very much.